Hello friends, this is Nishan. Indeed, it feels very good to resume the ECG series with an interesting and perhaps very important topic, that is bradyarrhythmias. Now, when do you say that a person is having bradycardia? Yes, that's correct. When the heart rate is less than 60 per minute. So let's have a look at various bradyarrhythmias. The ECGs and diagrams in this video are borrowed from following two websites: ecg.utah.edu and ecglibrary.com. Let's have a look at first bradyarrhythmia, that is the simplest one, that is sinus bradycardia. Sinus bradycardia is defined as an ECG in sinus rhythm with a heart rate of less than 60 beats per minute. ECG being in sinus rhythm, there should be two things, like P wave should be upright in lead 1 and 2, and each P wave should be followed by QRS complex. So if this criteria is met on an ECG and the heart rate is less than 60 beats per minute, the patient is said to be in sinus bradycardia. What are some causes of sinus bradycardia? Number one, physiological causes like sleep and in athletes. During sleep, there is increased vagal tone. Now this increased vagal tone, it inhibits the AV nodal conduction. This inhibition of AV nodal conduction causes decreased heart rate, and this decreased heart rate is manifested as sinus bradycardia. Then in athletes, due to increased demands of their body, the stroke volume is increased. This increased stroke volume causes increased stimulation of baroreceptors. Increased stimulation of baroreceptor again increases the reflex vagal tone, and this increased reflex vagal tone, what it does, it again inhibits the AV nodal conduction, and that in turn results into sinus bradycardia. What are some pathological causes of sinus bradycardia? Number one is acute inferior wall MI. What happens in acute inferior wall MI is that there is ischemia of AV node. This ischemia of AV node results in decreased conduction through the AV node, and that results into less beats that are conducted from atria to the ventricle. Although the heart is in sinus rhythm, it is in sinus bradycardia. Then in hypothyroidism and hypothermia, there is decreased basal metabolic rate. This decreased basal metabolic rate manifests by decreased demand, and this decreased demand can be met by a low cardiac output or a low heart rate. And this low heart rate, heart is in perfectly fine condition, but the heart is beating at less rate than a normal person, and it indeed is in sinus bradycardia. Continuing the discussion of pathological causes of sinus bradycardia, the next one is cholestatic jaundice. The cholestatic jaundice, what happens in it is basically there is increased conjugated bilirubin concentration in the blood. This increased conjugated bilirubin concentration has a direct inhibitory action on SA node. This results into decreased pacemaker activity and decreased heart rate. And on ECG, it is seen as sinus bradycardia. Then in raised ICP, what happens is that the blood flow to the brain is decreased. So decreased blood flow to the brain is perceived as hypotension, and this hypotension causes increased, that is, reflex vasoconstriction in the entire body, and that increases the peripheral vascular resistance. Now, as a result of increased peripheral vascular resistance, the blood pressure increases and a state of hypertension occurs. This state of hypertension again causes increased stimulation of baroreceptors, and this increased stimulation of baroreceptors increases the vagal tone, and that in turn causes sinus bradycardia. Then sick sinus syndrome basically is dysfunctional SA node, and various drugs, there are quite a few drugs that cause sinus bradycardia. Few important ones are beta blockers, that is propranolol, atenolol, metoprolol. Then non-dihydropyridine calcium channel blockers like verapamil, and drugs cardiac glycoside, digoxin. Let's have a look at one ECG, and if we look at the lowermost lead, that is V1, if we start marking the R waves and we start looking for RR interval, if this is the first R wave, then this is 300, this is 150, this is 100, this is 75, this is 60, this is 50, this is 40, and so on. So the heart rate for sure is less than 60, which tells us that this is a bradycardia. And if we look, if the ECG is in sinus rhythm, we can say that lead 1 and 2 P wave is upright and each P wave is followed by a QRS complex, which tells us that this is a sinus bradycardia. If we start marking the RR intervals and we compare them, if this is one, this is the next one, this is the next one, we can pretty much say that these are equal and the ECG is also in regular rhythm, which reinforces our diagnosis of sinus bradycardia. Then looking at AV nodal blocks, that is, there are mainly three types, that is first degree heart block, second degree heart block, and third degree heart block. Third degree heart block is also called as complete heart block, and second degree is further divided into two types, that is Mobitz type 1, that is Wenck-Bach phenomenon, and Mobitz type 2. Coming to the first degree heart block, what happens in first degree heart block is that AV nodal conduction is delayed, and that results into PR interval, that is this start of P wave to the beginning of QRS complex. The PR interval is more than 0.20 seconds. So the normal range of PR interval is 0.12 to 0.20 seconds, and when the PR interval is more than upper limit of this, the person is said to have first degree heart block. Now it is important to remember also that it rarely causes any symptoms and usually does not require any treatment. Prolonged PR interval is one of the Jones criteria, is one of the minor Jones criteria for acute rheumatic fever. Let's have a look at a couple of ECGs. If this is an ECG and we start marking the PR intervals, we can safely say that the PR interval is definitely more than one large box. The duration of one large box is 0.2 seconds, and which also happens to be the upper limit of normal range of PR interval. So in this ECG, we can say that the PR interval is prolonged. That is why this is an ECG of first degree heart block. Coming to the next one, if we look at the lowermost strip on this ECG, the P wave is somewhere here and the QRS starts here. So the P wave to QRS complex, the distance is definitely more than one large box. If we start marking the subsequent PR intervals, they are identical and they are more than one large box. So if the PR interval is more than one large box, the diagnosis most likely becomes first degree heart block. The second degree heart block is divided into Mobitz type 1 and Mobitz type 2 heart blocks. In Mobitz type 1, there is progressive lengthening, and progressive lengthening is the keyword of PR interval, and then there comes a dropped beat. This continues on happening and the cycle repeats itself. It is also called as Wenck-Bach's phenomenon, and it generally indicates a disease of AV node. Then Mobitz type 2, the PR interval remains constant, however some P waves are not conducted and that results into a dropped beat. It generally indicates disease of His-Purkinje system in opposed to the disease of AV node in case of Mobitz type 1. It carries a significant risk of asystole and should be treated with a permanent pacemaker. Now let's have a look at few ECGs of these two disorders. So if this is an ECG and we start marking the PR intervals, suppose P wave begins here and QRS is here, then P wave is here, QRS is here, then P wave and there is no QRS, then again P wave is here and QRS is here, then this is P wave, this is QRS. You can say that the PR interval is progressively lengthening and there is a dropped beat. So this becomes Mobitz type 1. If we start marking PR intervals in this ECG, this is P, this is QRS, this is P, this is QRS, this is P, this is QRS, again P and QRS, and then after P there is no QRS. So there is no QRS, so there is a dropped beat here, and you can easily say that the PR interval has stayed constant. However, there still comes a dropped beat, which makes this a Mobitz type 2 heart block. Then the next one, if this is P and if this is P and this is QRS, this is P, QRS, there is P, there is no QRS, that is dropped beat. Then if this is P and QRS, this is P and QRS, then again there is P wave but there is no QRS, so there is a dropped beat. The PR interval is staying constant and there is a dropped beat, which again makes this a Mobitz type 2 heart block. Coming to the next ECG, I like to keep my focus on the lower strip. If this is the PR interval, then if this is the next PR interval, if this is the next PR interval, and if there is a P wave but there is no QRS complex, so there is a dropped beat, we can easily say that the PR interval is progressively lengthening and there is a dropped beat, that is there is non-conducted beat. So this becomes Mobitz type 1 second degree heart block. Coming to third degree heart block, that is third degree AV block or complete heart block, there is complete failure of AV nodal conduction. So the atria and ventricles are beating independently. In this you will see a regular rhythm and bradycardia that doesn't get better with exercise. So mind you, this is a keyword that is oftentimes given in clinical vignettes, that the person is having bradycardia that doesn't get better with exercise. This is also known as AV dissociation and is a serious condition. It again, in addition to Mobitz type 2 second degree heart block, is an indication for permanent pacemaker. Let's have a look at few ECGs. The first ECG of complete heart block showing lead V1, that is the upper one is before pacemaker and the lower one is after pacemaker. So the P waves are coming at their own pace and the QRS complexes are coming at their own pace, and they indeed are regular. So this is an ECG that is in regular rhythm, is in bradycardia, and is the atria and ventricle are not in synchrony. So this is an ECG of complete heart block. Then the lower ECG, lower strip, you can see a vertical line just before the QRS complex. This generally indicates a pacemaker. So in this case, as this is lead V1, most likely this is an right RV pacemaker, right ventricular pacemaker, and they have paced the heart at a certain rate. So most likely you can infer from this ECG that this is, if this is the first R wave, this is 300, this is 150, this is 100, and this is 75. So the pacemaker rate is mostly 75 beats per minute, and this is a paced rhythm. So this is how a paced rhythm looks like. In the next ECG, I again like to focus on the longer strips like this one. So if this is a QRS complex, this is one more. These are the QRS complexes, and this is the P wave. These are the P waves. You can easily say that these are not in synchrony. Like P waves are coming at their own pace and the QRS complexes are coming at their own pace. It is indeed in bradycardia. So this ECG is again showing complete heart block. Thanks a lot for watching the video, friends, and I will see you in the next video. Thanks and good luck.